Good afternoon or good morning, depending on where you are in the country. Thank you for participating in our second session on addressing COVID-19's impact on health centers, finance and operations, and response planning for future COVID-19 outbreaks and other emergencies. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. And before we get started, if you could just type your name, your health center's name, in the chat box just to get familiar with who is participating today. That would be great. We have plenty of information to cover today. Our panelist has a great session ready for you. So let's get started. Next slide. Before we get started, some housekeeping items. At this moment, all participants are muted. If you would like to participate, since this is a learning collaborative and we would love to hear from all of you. If you have any questions, you can either type your question in the chat box or use the reactions button at the bottom of your screen, and there is a raise hand icon that you can just click on it and then your line will be unmuted. If you would like to turn your camera on, that would be great. It's really nice to see all of you and get familiar with each other. David will be asking some questions. So if you have any responses, again, you can use the reactions button, or you can use the right hand icon, or you can just type your question. At this moment, the session is being recorded. And just to remind everyone that the slides and recording links will be sent via email within a week after the session. There will be a survey or a poll question that is going to be shared with all of you in the chat box. So if you would like to have some sessions in person with David, or have some conversation about any issues that you have, he would be more than welcome to talk to all of you. So this is more like a business hour kind of session. So please make sure that if you are interested, you can use the link that is right now in the chat box. So let me introduce David. David Wagner has been a management consultant to physicians since 1985. He's skilled at all aspects of running medical practices, specifically FQHCs and RHCs. He has run practices of all sizes, from single practitioner practices to multi-specialty, multi-service line FQHC systems. He's skilled in optometry, pharmacy, primary care, dentistry, and behavioral health, along with the specialties generally seen in FQHCs and RHCs. He's knowledgeable on 340B operations, whether they be in-house or contracted to outside pharmacies. Davis earned his master's in healthcare management from the University of New Orleans. He completed his undergraduate in international business and finance at Loyola University in New Orleans. And Davis handles strategic planning, board training and review, CEO training and review, as well as general strategic program for the group's clients. He also acts as CFO in the shared CFO system and handles all aspects of HRSA financial and operational reporting, including UDS. Good afternoon, David.
Afternoon, everybody. How's everybody this afternoon? Thanks, Jose. So if you want to, next slide. So this series is basically looking at what COVID-19 did with regard to finance and operations in the health centers. Next slide. Today, we're going to be talking about the cost issues in particular. Last time we did discuss the revenue issues. So if you missed that last meeting, I believe it was recorded. But today we're talking about cost issues. Next slide. So the series itself, first of all, we survey the effects of COVID-19. We identify factors experienced by your own health center, and then we formulate a response plan so that you can respond to any future COVID-19 outbreaks or other emergencies. Next slide. And the takeaways are going to be that you'll understand how it affected things. You will understand how it affected your particular health center, and you will have your response plan in place so that you can weather any kind of future emergencies. Next slide. Today, again, we're talking about the cost issues. So specifically, I should have said financial costs. We're not talking about goodwill costs or staff morale costs or things like that. Obviously, we have to look at those things as we're dealing with this topic, but today it's really the financial costs of running the health center. Next slide. So hopefully by the end of this, you're going to understand those costs, how they affected your health center. And again, you're going to have that cost section of your response plan done. Last time we did the revenue section, so this time you're going to do the response for the cost section. Next slide. So what is a cost? That's something that you paid for something, a price, a disbursement, an expenditure, an outlay. And again, financial costs is what we're talking about, not the other costs of what we weathered during the pandemic. Next slide. So I have very briefly discussed all the different lines on table 8A, which are basically, as you guys know, the UDS categories and how we report to HRSA the costs. The reason I use this structure specifically is so that you can measure against the nation, your peers, and against yourself using a strong or a strict format that lets you compare apples to apples. So I'm going to very briefly go through this, but it's all here. I've also got the links to the UDS manuals for you, but I just want to bring out some very specific things that we're dealing with in the different line items. So again, when you get into the next section of analyzing how it affected your health center, you can make those analyses. So we all know line 1 is medical personnel salary and benefits. Does not include the value of volunteers. However, I would invite you to make sure that you capture that value in other places in case you relied heavily on volunteers to fill in during the crisis. Next slide. Lab and direct x-ray costs. So that means things that you actually provided or paid for in columns 1 and 2. Does not include things on column 3, although you're going to see as we discuss things in a collaborative nature, you still need to kind of understand where those patients were able to go to get that care during the crisis. Next slide. Other than personnel direct medical costs don't include donated goods. So, you know, I know we were all asked during a lot of the surveys and things that HRSA was doing, what did you get donated to you? What was the value of that? There are places in the UDS report to put that, but specifically in this table here, we're not putting the value of the donated goods at this time. You also don't include any of the medication costs or the cost of providing pharmacy there. Next slide. Dental, that one is everything that you need to run that dental. It actually includes the supplies, any kinds of medication specific to dental, any injections specific to dental, those types of things. Next slide. Mental health, same thing, anything specific to mental health on line 6. You guys know we've broken out substance use a little differently now, so anything for substance abuse is line 7. Next slide. Line 8A, pharmacy, this line is for running the pharmacy, does not include the cost of drugs. Next slide. Line is anything else. Go ahead.
I'm sorry to interrupt you. You broke up, but you're good again.
Yeah, so anything other professional services provided except for emotional. Okay, next slide.
Sorry to interrupt, David. There seems to be something going on with your microphone. You keep breaking up. Yeah,
That better?
I think so. But
If I run out of juice, it runs out of juice, I'll take it off. Okay.
yeah, it's
Let me just do that. I'm gonna just take it off. Because I might have some noise behind me, so I was trying to not use. Is that better?
yeah, much better.
Is that better? Okay. So, next slide. This lines 11, A through H, as you know, has everything to do with enabling services. That's not necessarily your front desk that all they do is check patients in and out. That's truly supposed to be the people that are actually enabling patients to come. That could be some of your staff that deal with Medicaid enrollment, things of that nature. Next slide. Other program related, those are the WIC. A lot of people have WIC, some people have housing. Any of those other types of things would be on that other program related. Next slide. And quality improvement is its own slide here. 12A is online. Next slide. 14, this is a really important one. And I'm going to show you some findings that I found interesting as I looked across UDF across the 3 years. But these are primarily your fixed costs to maintain the facilities themselves. Next slide. And then 15 is everything else. So this is where you would have those front desk people that are not necessarily people that are helping patients get into Medicaid and other insurance plans, but just doing the business of checking in and checking out as a regular medical practice might do if you weren't an FQHC. Revenues like the medical records. This is all the C-suite, the executive here. All these people sit here.
What the heck?
Okay.
Call me on Tuesday?
Next slide. Did you have a question? Oh no. Next slide. So the reason this is so important is that when we're doing our calculations of what the costs are to run the practice, you actually allocate all of these facility costs that are not really having to do with direct care provision using these next few steps. And you're going to see that all of that then populates column C of our UDSs, which is really what we use to do all the calculations for medical costs for medical visit and all those types of things. So it's really important to have these in the right places as you're going through this. So the first step is really just you have those costs, and then you try to allocate those to each cost center specific to, for example, if I have a medical practice and I know I've got 6 exam rooms, some space for the providers, there's certain specific areas of that office that are for that particular primary care. You would allocate those up to line 1, but over into column B, which would then add up to be in column C, which is what we use. Any kind of contracted services, things like that would also be in that realm. Next slide. Okay. So the last thing is going to be anything that's left over, because you'll have money that's left over. You would basically just allocate that across all of the expenses in one line item that are such as maybe by patient visits or ratio of the direct cost. You're going to have some internal allocation formula that your CFO uses to do these types of things. But what you're going to want to do is make sure all that is there correctly so that you can use your data on a monthly or quarterly basis. I propose monthly to do these comparisons. So that's your basics about UDS. I know all of you guys probably know this inside and out, but I like to start here because it's an important concept to be able to move to the next parts of the discussion. So next slide. So, oops, okay, next slide, sorry. That's where all your donations go to. on line 18. So that's the next slide. So here's what I found. I did some analysis of the UDS trends over 2018 to 2020. Of course, 2018 was our last normal year of life. 2019 was just about a normal year of life. But then 2020, we all know what happened. Unfortunately, we don't have 2021 yet, but I would invite you, I've already done a lot of analysis for a lot of my clinics using our own internal 2021 data and just kind of comparing it to the benchmarks and the trends of what we saw. But interestingly, look at the total cost structure went up to 33.18 billion across all of the FQHCs in the nation. So this is a very striking issue. We all experienced it because we all knew costs went way up and revenues went way down. And you know, it was just a very trying year for all of us. Next slide. But I wanted you to see these differences. So medical is the bottom green box. It went 15, 16, then to 18. Other clinical, which is just about all the other services, went from 9.4, 10.7 to 11.2. Enabling, that's all of those things, those services on the UDS that are below the vision and other column, 3.1, 3.4, 3.7. And then donated services also went up slightly, about a half, about 0.6 and about 0.7. So you see that all of these different costs went up over time. Next slide. But look at this, the patients really went down. So I found, again, this striking, and I know it looks like a huge amount just because of the way the graphs laid out. We went from 28 million to 29 million, back down to 28 million in 2020. So the bad part about this is our costs went way up, and we see that our patient counts went way down. Now let's look at the next slide. This is again just kind of demonstrating that strange difference. And again, this is part of where you start comparing yourself. The total cost per patient in 2018 was about 1,000, went up to about 1,064, but then it jumped up to 1,182 in 2020. And the reason I bring this out is you can do these analyses for yourself, for the nation, for your state, and you can even find some of this data on some of your peer organizations very close to you to try to get a feel for how you shaped up against what happened in the rest of the country. Next slide. So where did this go? What did all this happen? These are the different service line types and the different cost groupings that you can see happened over the 2018 to 2020. Again, this is the national data off the national UDS reports. About 62% of the total care costs were for medical in 2018, and you see it went up in 2019 and then back down in 2020. But again, what's striking is the patient counts went up and then back down further in 2020 than they were in 2018. So we spent more money on medical than we probably should have in 2020, as opposed to 19 and 18. Substance abuse, you can see that one shifted significantly up and down. And I don't know if you guys sensed this in your actual clinics, but we had a situation where substance abuse patients would not be coming in. For some reason, they didn't want to do it over the telephone. It was really an interesting situation, at least in the clinic where I was during the pandemic. So again, you would just compare and use this data to compare and contrast against some of the others in your area in the country. Next slide. In the visit type trends, interestingly, substance abuse here looks like it held its own. but look what happened with the primary care visits. They went up slightly in 2020, but we saw that that cost went up significantly for 2020. So and again, it's just interesting to look at this and make those comparisons. Next slide. So medical costs per medical visit. And I've got a couple of ideas of what has been driving this, but it's very possible that you could look at some of these issues in your own health center and see if you're finding similarities. See how it went up significantly for 2020. What I found in the health centers that I analyzed was that because the fixed costs didn't change dramatically between 2018 and 2019, it didn't seem like there was, it didn't seem like the inflation for just the fixed costs themselves would have much effect in 2020. But when I went backwards and looked at it, I actually found fixed costs actually rose in many of the health centers where I was. Variable costs rose even higher. So even though the visit counts and things shifted, which would have made me believe the cost per medical visit would be pretty close in 2020. I think a lot of this has to do with the fixed costs rising and outpacing the variable costs, but still the variable costs rising higher and faster than the loss in medical visits, which caused that increase. And again, if you look at those types of things and you look at all the different pieces of your financials and where they impact those line items on the UDS, you can start reading into some of that information for your clinic. Next slide. The dental costs went up significantly. This one was because during 2020, we found one of my clinics, they were closed for almost 6 months because the pandemic would come. As soon as it started opening back up, another wave would hit them. It was horrible in them. They were down in New Orleans. So I think the fixed costs were the piece of this that were worse. But even those clinics, when they came back, do you guys remember all the PPE we had to use for dental? So those costs for that, the variable costs per visit, just because the PPE went up significantly. So I believe those are the drivers that drove that increase in the dental cost per visit over that time period. Next slide. So what did we find? Everything rose. I mean, I know that's an obvious statement. We've all been feeling that. Visits dropped, which really caused that cost per patient to rise significantly, and the cost per visit rose sharply. Next slide. So how do you bring all this home? Look at the telehealth visits, the percent of health centers that did those. 2018, about 40, less than half. 2019, and then in 2020, obviously, we did about 100% of the health centers having telehealth visits. I think there was a couple that didn't. Next slide. And look at the service mix they did. I was surprised to see oral health even go up at all. I know that you can do that, but I didn't have any health centers that did that myself. But look at primary care. Of course, that one we can see went up to 100. Behavioral health, interestingly, it went way up, and it was actually a very good way to deliver that care, at least in the centers where I was. But then I noted how many people used to already do telehealth behavioral health. I just had never had any health centers that did it that significantly before. Next slide. Cost of telemedicine. This is one of the costs that did go up. I think it went up around the country just because more people were starting to do it. I didn't really hear anybody that said their costs went up because of telemedicine costs going up themselves. I really think it was just because it was an additional cost for most places. Next slide. So this is an example of something you could use to capture all this data. This is just a monthly operating review dashboard. Some of my clinics actually did a COVID dashboard so that every month during the board meetings, they were looking at the cost per visit, the total cost, how many FTEs were in those departments, some of those types of cost drivers and revenue drivers that they could make some comparisons. Most people compared against the prior fiscal year just because that was the last quote unquote normal year. But you may come up with some other method of making these comparisons and analyses that makes more sense for your system. Next slide. So what happened to your health center? I would recommend using table 5, which is the FTE counts and the visit counts and the patient counts, and compare those against your table 8A, which is the cost. And table 8A is the one we went through pretty briefly in the beginning in a little bit of detail. What I would recommend is make sure your systems are able to get that data out by month. You can compare that to your budget. So most people do a financial budget. I do what I call a UDS budget in the health centers, where you budget every aspect of the UDS report down to the FTEs, so you can see if there's any shifts or correlations just from the budget, operations, finance, revenues, and even the metrics regarding the quality measures, the health indicators. So compare that to your budget, compare it to last year. If you've got as your systems well enough tuned up where you can compare to the same period last year, the same year to date last year, you know, all those types of comparisons can really help you get at that data and see if you've got shifts or trends that you're seeing. Compare the nation, obviously, and then compare at least to your state. A lot of the states will actually help publish de-identified data in regions as well. And the reason I say that is because some of the cost metrics you can't get to at the individual health center level. So it's hard to get it at that regional level, but at least you should be able to get that to the state level. Next slide. I also like to look at all of these costs to the different types of patient visits. I look at the service lines and roll them up that way. I look at the locations and roll them up that way. What I discovered in one of my health centers is that there were certain locations where the cultural sensitivity was less acute to the pandemic. So they actually didn't have as wide a fluctuations in the costs and the cost per visit and things like that, because people weren't avoiding care. In that same health system, in other parts of the area where they were very sensitive to the pandemic, you know, those were the ones where dental shut down completely. They had an optometry practice in one of the locations that was completely shut down, and a lot of the visits shifted more to telemedicine rather than face-to-face. So it's interesting to be able to see those trends across different locations and service lines. Of course, the service lines, unfortunately, we saw that anything that required face-to-face, like dental and optometry, was pretty much closed. So you had those fixed fees and you had your employee fees, but you didn't have any revenue or anything like that coming in. Next slide. Look at the cost efficiency. So another thing that the health centers do is they will actually look at the provider time in clinic and compare that against the costs that were incurred and the revenues that were realized. Then they would look at the telehealth and see if that was a more efficient method or not. I had mixed reviews. Some health centers, the ones that had been doing some telehealth already, seemed to do a lot better because their efficiency picked up and they were actually able to see more patients in that same time period as they would have seen them face to face. The unfortunate part is that particular state for Medicaid didn't pay very well for telehealth. So the revenue
still dropped, but the efficiency rating went up. So again, it's just an interesting thing to look at. Quality measures, just about everybody suffered significantly on their attainment of quality measures, just because some of the face-to-face requirements, they couldn't close those gaps because people weren't coming in as much. And then the clinical outcomes, that's more if you're in managed care or have a lot of value-based contracts where you could actually see, okay, this month I had 5 people go to the emergency room, but after the pandemic, 20 went, not related to COVID, you know. So if you have any way to track your clinical outcomes, that's another interesting thing to look at and make comparisons. And this is all important because you got to know how to respond the next time. So next slide. I kind of throw these things out there, so let me stop and say that a trend is more of, you can see something, even if it's an exponential trend where it starts to like skyrocket, that's still a trend. And it may take a little bit longer to happen. And if you can compare that to the different weeks in March, April, and May of 2020, you know, it's like, you can kind of get a feel for, okay, that's something that's going to happen eventually, but it might not be an emergency. A shift is an emergency. Like, you know, when we saw the city shut down and then dental went to 0, that's a shift. So I just want to make sure you can recognize those differences, because a shift is an emergency. A trend is something you really got to deal with, but the magnitude of that trend might be a little bit more manageable over time. That makes sense? So go to the next slide. And if people have questions, please chat them in. So, okay, now I've seen what happened in the rest of the country. Now I'm kind of getting a feel for maybe what happened to my system specifically. Now let's talk about how we're going to prepare for the next one. So next slide. And again, we're just talking finance, but I still use the overall infrastructure of the emergency response plans. And you'll have the link to that soon. Understand the cost per visit type. That's very important, because so you've got, let's just say you've got, and I'll keep it in the medical care area. What if you've got a huge OB department? Probably not the best example, but it's an example. Let's just say that that whole OB department, you see that when you start doing the analysis month by month, the cost for that department based on the number of visits skyrockets. You've got one of those shifts. That could indicate an department that you want to furlough, as opposed to another department that the costs might have just gone up steadily. You got to kind of make that determination, because if something's going to cause you a huge cost shift that's like a jar to the system, you may need to figure out ways to outsource that or collaborate on that right away, so that you kind of insure yourself against some financial downfall. Okay, next slide. And then which were lost drivers? So you always need primary care, but what about the other clinical departments? Lost drivers might be some of those where they've got that slow but steady increase, that trend line where the cost per visit is going up. Just kind of consider which ones were lost drivers. And the good thing is we can all do a retrospective review, and that's why I like it by month. You can see these shifts and trends, and then you can kind of at least surface that data and have some good open discussions about this. Next slide. And I'm not saying that we would ever want to stop caring for our patients, so don't get that at all. But other collaborators in the community might be better and more equipped, and maybe have, you know, that they've already got that fixed cost so that they can accommodate these patients better than us continuing to try to do it. Hospitals, collaborate with some of your hospitals, see what services they might be able to do, and you figure out how to create a synergy in the community by letting them handle some of the services instead of you continuing to provide them. Your fellow lookalikes, rural health centers, other FQHCs in the area. Actually, there's one area that I work in that they're very collaborative, and they actually all collaborated and essentially divvied out who was going to handle what types of things during the pandemic so that they could consolidate. Theirs was not driven by finance specifically. Theirs was more driven by just the staffing outages where, all of a sudden the whole department would have COVID. So they were under that kind of a realm where they were trying to just make sure patients got taken care of. And then private physician offices, several of the health centers reported that private physicians would actually close their practices and come see patients within the health center world. So again, there's lots of different ways you can collaborate with people out in the community. Next slide. So cost efficiency, this means, this is your cash flow. We talked about revenue, that's volume and price. Now we're really talking about that operating margin, the cost of goods sold, your different costs for just providing the services. Kind of in the same way you're looking at the medical cost per medical visit, you can determine which costs actually have an efficiency where you can look at the cost itself over the revenue it produced, or you can look at the cost itself over the shift or the trend that you saw to come up with that efficiency metric. Once you do that, then you can dig deeper into that cost to see if there's anything you can do to reduce it through automation, making better deals with suppliers, or just tweaking your payroll, your overhead. We're going to talk about some of those things next, or just trying to figure out how you can deliver that service perhaps at a better location or a centralized location. I know a lot of this sounds very like not concrete, if you will, but if you start this process of just looking at things and massaging through the data, these things I promise you are going to explode. They're going to come to light. Next slide. So let's talk about staffing costs. That's the one, and this is red, green, and yellow because of its detrimental effects on the organization as a whole if you have to take quick action. Staffing costs, that's obviously the largest cost in any organization, right? Layoffs, don't want to do them, but we had some health center locations that they just had to shut down because there were no patients coming in. There were, it was just impossible to do business because the cities would basically shut down. So layoffs is something you have to do, but it's red because it's the last thing I would do. Hiring freeze, early retirement. Those are in yellow because those can cause staffing issues later where you're not going to have enough staff to cover the business that you've got. So you really want to try to do those very carefully as well. And I don't think I put in here too, attrition. Well, I guess the hiring freeze is. So as people are leaving just under normal circumstances, you don't hire back into those positions. But if you're going to do something like that, you got to make sure, we talk a little bit about that in the staffing in the next one. You have to make sure you've got those plans in place to then cross-train staff and be able to have them be flexible to move around the system, pretty much on a moment's notice. Next one is furlough. A lot of people did this, and again, it's not comfortable, but you may have to just furlough workers for a day or two a week, or just reduce their hours if you need them. But again, you got to be careful because you may lose people, number one, but it's also very difficult to recover and get your business back in normal operations if too many of those people leave. So again, it's a risk. Reducing wages, freezing wages. Freeze is yellow because most people would kind of agree that, okay, if we're in a bad situation, I'm going to have my job. I'm not gonna push you for that extra $1 an hour. But it's in yellow because some people they could need that revenue, and it would cause you trouble. Voluntary unpaid time off, that's in green because that's more like something you just throw out there. Hey guys, we're having this situation. Does anybody want to do this? It's actually green from the perspective of the employees, but it's still not a very comfortable situation for the administration, having to figure out how to deal with all of that and reallocate those work resources. Freeze, reduce incentive compensation plans. I had one that was very successful in this, and it didn't lose any providers, and it was a pretty significant cut. 25% of this FQHC's provider compensation was based on incentive plans like quality and production and things of that nature. That CEO was able to negotiate with the providers. They basically froze those payments in time, and to my knowledge, are still frozen, that they would be able to then reap that money over the following several years once the pandemic had ended. But again, that's one that you want to consider. Most executive incentive plans I saw were frozen. So another one you can do is suspend the employer 401k match. Again, if you guys did this, if not, it might be something interesting for you to think about. But if you match the 401k, that's a pretty easy one, unless you're in a plan that requires a minimum contribution for the plan to remain in compliance. Most plans, there's an emergency ability to either suspend or remove a match, but you got to check your plan documents to make sure you don't mess that up, because you don't want to do that either. So I guess that should be yellow. Green, if you can deal with it the right way. Yellow means wait, make sure you're not going to cause a problem if you do that. Merit increases, again, most people were fine with that as far as the staff. Shift healthcare premiums to employees. This is a tricky one because you have to shift at the same ratio for everybody. So, your lower paid staff would have a lot of problems with this, but the executive team shouldn't have any problem with this at all. But so that's why it's yellow. You got to be careful with that one. Suspend all kinds of expense reimbursements. So that's one area that I found a lot of fat in one of the FQHCs. So we basically just looked at who's physically traveling between offices and worked on scheduling to where that movement went down. So we were able to reduce this quite a bit. Travel, conferences, that kind of happened naturally, but I would ask you to be more proactive in that thought for future, because that saved a significant amount of money for a lot of the big entities. No NACHC conferences, no regional conferences. All that stuff shut down and went virtual, so it saved quite a bit of money. Same thing with CME time. We actually had one health center that had a pretty expensive CME budget, and all we did was we looked for the free CME options and just asked everyone to shift to that, because we weren't going to do any kind of reimbursement any longer for paid CME. Didn't pay them for the time. They did that on their own time. The courses themselves were also free because they were the ones that came along with different magazines and organizations and things like that. And then pay premiums. If you have a system that has a lot of nursing staff that have shift differentials, that can be a good one to just freeze it or remove it temporarily until the emergency is over. Next slide. And then these are the other costs. And these are just some thoughts of things that either I personally did or one of my health centers reported having done. So I'll have you kind of read through those once you get the slides. I'll bring up some big ones. I was able to renegotiate Stericycle, which is a huge expense to most of the clinics. Not only did they reduce the amount per pickup for one of my locations, and this was a pretty big health center system, we also worked with them to ensure that every time they picked up, those boxes were completely full. So not only did we reduce the pickup fee, we reduced the frequency of the pickup fees by half. I'm not to say that we shouldn't have done that before. It's just that COVID really brought it up. Plus, when they did pick up, they picked up fewer boxes. So that really made a huge difference. Staff took very good care in making sure what they were putting in those boxes. But I'm telling you, that's a big one right there. Negotiate with your vendors. So I had several vendors that I began to offer, because thankfully I had the cash flow. I began to offer, okay, as soon as I order, I'm going to pay you, but I want a 15% discount to do that. You know, I know you give me net 10, but I want 15 off if I pay at time of order. It wasn't a credit card. We did an ACH type thing. So that helped a lot. And that was my big vendor. I probably shouldn't say who, because they would get angry with me, but that was a big vendor, and we were spending sometimes 100 or 150,000 a month on supplies with that vendor. So that was a significant amount of savings. Cancel unnecessary services. As I looked through the contracts at one of my larger systems, I was amazed at how many services we were using, outsourcing, these little things that our current staff, that now that we had fewer patients, could easily handle temporarily. So we renegotiated agreements to either let them suspend or cut off for a few months until everything could normalize. So think about that. And then, of course, the large meetings, we stopped having in-person board meetings. We stopped having in-person system meetings. And I found very quickly that we saved a lot of money in the budget, because no more food, no more drinks, no more gas, no more, there's lots of expenses that revolved around those meetings that we did just as well using Zoom. So think about those types of things. Next slide, I think I have a couple of others. I talked about that. Oh, vaccine supply. So I know you guys probably already grapple with this. You've got explorations, you've got duplicate vaccines sitting in all these different places. I actually had a system that I had done a first site visit for, where I learned about a company that just provides the vaccines and bills for them. They manage all the expirations. They manage all the billing. They do all of that. I switched this huge system to that company, and we saved a lot of money just on those awesome backs. I mean, it was ridiculously the amount we saved. So that's something that I would invite you to look into. Just the old adage about conserve, 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 and off the darn lights. I mean, I was amazed at how much our power bills went down because we consolidated the accounting department into the billing department. They were on top of each other, but it was such a huge organization that it let me close down half of the building, turn off half of the power, half of the AC. I mean, it was ridiculous the amount of money we were spending. So think about those types of things. Eliminate all the mailings to patients is another one. Instead of using expensive mail, just sell SMS, email, those types of things. Next one, I think we're going to bring it home now and talk about the actual plan. So you guys that have done quality improvement cycles on all of your health measures, I invite you to do that on cost. This is kind of new to most people in finance, because we really haven't been able to do that. So what I would highly recommend is you take the infrastructure, and here's the link right here. If you go to the next slide, I can show you that PSA infrastructure, Plan Deep Study Act. The next slide. So this is the form, and all the guys and gals that are used to doing the quality measures, this looks like very, very, very familiar to you. What I would invite you to do is ask your quality improvement director, hey, can I use your team and your infrastructure for a little bit to kind of do some quality improvement metrics on some of my costs? We already did this with revenue last time, but and I think I have another example. Go next to the next slide. If not, we'll have to. I did it. Okay, so leave it there. But what you do is you take something like reducing the overhead of running my administration office. And then the first tool they use is something called a fish diagram, where you basically take the head of the fish over here, where his little nose would be. That is the reduction by 20% of all costs of running this building. And then the spines of the fish, the bones and all that stuff go back like this. And you're putting on each one of those spines the major aspect that would have an impact on reducing the costs. And then, if you will, each spine has little bitty filaments that go left and right. Each one of those little filaments might be close off room 10, or as an idea, or turn off the lights, or move people to a different room. All these different things to where it organizes all of this for you, and you get to those very minute steps that have huge impacts in have huge impacts as a group on that final impact that you want to hit. So they can help you with that. And then the plan, do, study, act cycle is, that's the planning, then you do it, then you watch it, and then you act on it and continue it if it seems to work. I'll have to tell you, a lot of the stuff we did, they've integrated that into their daily operations now, just to save money going forward. But the disaster plan, this slide shows you, and again, some of you guys that might be COOs or part of this piece of it, this is the disaster response plan. Most of this infrastructure has been set up to help physically respond to a disaster, but there's also pieces of it that are the financial response, operational response. You can use this to kind of look inward and figure out how you're going to respond to the next disaster using this infrastructure. So it's an excellent infrastructure. Next slide. So these are a couple of resources. I'm always a resource. If you can leave some questions, let me know. If anybody has any questions right now, because we have a couple of minutes, you can email them in. I'm always happy to respond and help however I can. Okay. Thank you. Thank you for your time.
Thank you, David. If you would like to ask a question, again, you can use the raise hand icon. You can access it at the bottom. There is a reactions button, and then you can use the raise hand icon and your line will be unmuted. Or you can also ask a question. You can use the chat, and then we are going to read the question to David. Also, do not forget that after this activity, we have a post survey. So we would love to hear from you, your feedback, your comments, suggestions, anything that you would like to share with us. There is the office hours doodle poll survey as well in the chat. If you would like to talk to David and use the opportunity of an office hour and ask a specific question to him, the link to the doodle poll survey is right there, and then we're going to get back to you. So please use any of these opportunities to discuss, ask questions, participate, share your best practices, anything that you need from us, from David.
I did want to ask, did anyone kind of start their analysis? We had sent out some suggestions, and everybody's busy as all get out right now, but some suggestions of some of the things that they have kind of sensed in reviewing their data. Has anyone been able to do that step? I think the assignment was to look at your costs and just look at and see any cost line items that had a significant shift in them. Remember that abrupt change. Does anybody have anything like that they'd like to chat about? All right. I don't know if anybody has any questions or anything. We have a couple of minutes we can give back then. If you have more announcements. And then next time, oh yeah, the sessional line. You're going to talk to them about that. The next one, I believe, is actually staffing issues. Am I correct?
Correct.
That's right. Yeah. So that's going to be an exciting one. We're going to have a guest speaker on that one as well, along with me, that talked about how they did some recruiting and things like that during the pandemic. More what I'm going to talk about is the operational issues with staffing that we experience. So then the final one on May 5th will be productivity issues. And those are the productivity issues with regard mainly to the providers, is what I was talking about there.
There is just a comment from Pamela Barnes. Thank you for the financial negotiation tips. Helpful, very helpful.
Good, thank you. Yeah, that helped a lot on the bottom line. So.
Well, again, if you have any questions, please feel free to contact us. Thank you very much for attending this session. Remember that we're having in 2 weeks our session number 3. So again, please make sure that if you need an office hour, you can complete the doodle poll that is in the chat. If there are no other questions, thank you so much for attending this one, and have a great afternoon. Thank you, David.